Let's join.
Good afternoon and good evening. Thank you for joining us for the last weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I'll be moderating this session. The weekly briefing focuses on health emergencies across the continent. And today we are joined by Professor Yap Boom, the Deputy Incident Manager from the Incident Management Support Team based out of DRC. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Muted. Muted.
Yeah, Prof, you're muted.
Yes, can you hear me now?
Yes, that's good.
Yes, okay, good morning, good afternoon, good evening, depending on where you are. It's my pleasure to lead you for that last press briefing of the year on the side on behalf of our Director General, Dr. John Kaseya. And then we'll go through some of the key events that happened this year, but also where we stand now. The year is ending. This is the last press briefing, but that does not mean that the activity, that the outbreak have ended. So we'll give you an overview of all that, and then happy to, as usual, engage with you in some conversation and question that you may have prepared. Over to you, Director Margaret. So it's been a very intense year. And then first of all, we are grateful to you as a journalist who are joining for this 66th press briefing, which means that since we've started the response to Mpox, you've really been here with us. So now I will go through some of the key events that happened during the year in no real order. I mean, we've been having different outbreaks, Ebola that happened in DRC, but also in Uganda for the same year. We've been having some Marburg outbreak, which happened in Ethiopia as we are speaking now, but also had happened in other countries in East Africa. But beyond the outbreak, Africa CDC has really been pushing on the sense of listening from our partners, from our leader during the different summit of head of state and ministers, but also engaging with all stronger partners, the World Bank, WHO, in different fora. And all that with the aim of pushing the vision of Africa CDC, which is an improvement of the new public health order, trying to bring on board the new components that we think are critical: the local manufacturing, the emphasis of pandemic preparedness and response, the domestic financing, some of the key activities, including the digitalization of the surveillance and actually the digitalization of health. So some of those of the key activities. Next slide. Now, again, during the United General Assembly, the UNGA, we have been attending different fora, including the forum roundtable on the 100 days, but also was the opportunity to have the extraordinary session of the Commission of Head of State and Government. This is the time where we listen to our leaders. And by listening to our leaders, it actually led us to adjust, to adapt the vision, the Africa health, security and sovereignty. It was also the opportunity to mobilize some resources for the cholera plan, as you will see as we'll go, and as we all know now, cholera is definitely at this point one, if not the major public health event that the continent is facing. But also there have been some critical events on the laboratory. You all know how critical the lab is for Africa CDC, is for the continent. And we have been happy to celebrate during the ISLM symposium that happened here. Next slide. Now, a bit more recently, last week, our Director General, Dr. John Kaseya, was in Kenya. And the visit in Kenya was really to push and support the agenda of local manufacturing and regional capacity building to strengthen long-term health security across the continent. It was the opportunity to commend once again the Kenya leadership in critically advancing the resilient African-led health system. And once again, the opportunity to ensure that the vision, the upgrade vision of Africa health security and sovereignty is aligned with the vision of the President of Kenya, His Excellency Ruto. Why? Because this is also our AU's champion for local manufacturing. So the Kenya is taking over to push for next year this agenda, including the organization of an extraordinary AU summit focusing on local manufacturing. So it was important for our Director General to go listen to the leader and ensure that they are well aligned we are aligned with their vision, and then we are also being able to support them on implementing those upcoming events. Next slide. As we mentioned a bit last time, we all know the challenge of reaching the last mile. We all know the challenge with those children that we call the zero-dose children. We have also faced the challenge during the Mpox of the low testing coverage in some places of DRC. All those issues are occurring because of the logistical challenge of reaching the community, of reaching the population. So in our continent, our people are still struggling to access to essential medicine, supply, but also diagnostic during the public health emergency. That's what it was critical to take that opportunity to sign this memorandum of understanding with Zipline to really strengthen the medical supply delivery. So the aim is really to expand the reliable delivery system, which also include, and especially, the reaching the remote and hard to reach area. Move us closer to a future where really we want no one to be left behind because they are living in a place that is difficult to access. So those innovation and those partnerships are critical for us to reach the last mile. Next slide. Still on the same, we are moving towards signing an MOU with Starlink so that we can also push the agenda of connectivity. There is no way we are going to transform in terms of digital if we don't have the proper connectivity. Last week, again, I mentioned that our Director General was having a meeting with 13 out of the 16 AU member states that are currently engaging on the bilateral discussion with the US government. So first of all, it's important to remind ourselves that Africa CDC is the only institution that is properly named in the America First Global Health Strategy, which means that we are definitely a renowned and recognized player as health is concerned in the continent. Now, the position of Africa CDC is all, of course, to support the member state, but to support the member state and ensure that the partnership respect the national priorities, to ensure that those agreements are aligned with the country plan for the health in the country. But also, our Director General added that this partnership protects data sovereignty, strengthen Africa's own system with support channel through government to government. We are moving to an era where the support was going through NGO, but really to a time where government will support government. And it was also to the opportunity to reaffirm to our member states that Africa CDC stand beside them in every step of the way. Next slide. Now, this week also, the WHO convened this high-level advocacy meeting on the issue of diphtheria. Diphtheria is an entirely vaccine-preventable disease which is resurging in the continent. We can talk about Chad, Guinea, Mali, Mauritania, Niger, Nigeria, and South Africa that were present during that meeting, but also the partners, UNICEF, Gavi, and of course, WHO and Africa CDC. So the commitment is really to strengthen the response to diphtheria across the continent. And from the regional director of WHO Afro was highlighting how this is an opportunity to reaffirm a shared responsibility. So we are all aligned that no child should die from a disease that we can prevent, and that the primary health care must remain a central pillar of the health security. So there is a clear alignment between us and WHO, and they emphasize that strengthening the community engagement and expanding vaccine manufacturing in Africa are critical to reinforcing routine immunization and primary healthcare system. So you can see how all those partners, all those organizations are aligned, moving in a coordinated manner to address this new issue or resurging issue of diphtheria. Next slide. Now, this year has also been the opportunity to share, to tell our stories. The publication that we had, either on the accelerating community healthcare workers, the new era for Africa health security and sovereignty, the new plan for cholera, the call for action to end cholera, and many others. We believe as a scientific organization that it's a must for us to ensure that our voice is being heard in those scientific fora where we can send our vision, we can send the experience that we see in the country so that we can influence the way countries are implementing the security and their sovereignty. Next slide. Now, at the end of the year, we are looking at where we stand in terms of the top 5 outbreaks in 2025. When we look in terms of member states, Mpox is the first with 28 countries affected, cholera 25, measles 20, dengue 11, and Lassa fever 4 member states affected. But now, if we move in terms of suspected case and also death, definitely cholera is the top major challenge that the continent is facing, as we'll see during this presentation. But what is important is to see that as we move toward the end, we have more or less 1 week or 10 days remaining before we close the year. You can see that the number of moderate and high-risk events in 2025 are less than what we had in 2024, which is a good news. It is a good news emphasizing the way countries are also most likely improve on the way they prepare, on the way they respond to some of those outbreaks at the source before it's coming much bigger. It might also be a testimony of the way the collaboration between the different organizations on working on those different public health events is strengthening the capacity of countries and therefore allowing them to be stronger, to be faster, to be more efficient on responding to those outbreaks. Next slide. Now, this year has been also the year of Ebola virus outbreaks. The Sudan Ebola virus disease happened in Uganda, and the outbreaks was declared end in April 26, and it was contained within 86 days, which was quite impressive in the term of detection, in the term of all the contact tracing, all the treatment, all the deployment that were implemented were quite reassuring, but also highlighting the capacity for a country to respond to those outbreaks. Next slide. Then follow the one of Ebola virus disease in DRC, which was declared ended on the 1st of December. And one of the common in those two outbreaks is that the time to detect, the time to sequence was significantly reduced, as well as the time to implement the use of new therapeutics that was used to fight against that disease. In DRC specifically, 48,000 people, 44,000, sorry, have been vaccinated. And this is one of the first time where we have this preventive vaccination, where we were coming from a time where we were using the ring vaccination around the contact and the contact, vaccination on the first-line workers, but also this time we implement the vaccination within the district, which has significantly played a role in controlling this outbreak within a short time. So it's an opportunity to remind ourselves that that preventive vaccination is an important way forward. 500,000 doses of Ebola vaccine are available at the ICG and can be deployed in countries in a region that are endemic to Ebola. For this outbreak in DRC, we lost 4 frontline workers, healthcare workers, because at the time they were dealing with patients, they did not know that it was Ebola. But just imagine now that if those people have been vaccinated, then most likely they will have survived. That's why it's critical as a lesson learned to ensure that we take advantage of those available, take advantage of the evidence that we are generating for those response, and therefore to push for the preventive vaccination. Next slide. The Marburg virus disease ongoing in Ethiopia. We are still at the week 50, which is still ongoing. We can see that the testing keep on improving with 2,000 samples that has been tested. We are still with 14 confirmed cases, 9 deaths, which makes a case fatality rate of 64%. So now, in terms of area that has been exposed, we still have the area of Jinka and the one of Awassa in the south region of Ethiopia. So what is also important to note at this point is the preparedness of countries that are surrounding Ethiopia. This morning, we were having the engagement with the colleagues from Somalia, from South Sudan, to assess how the level of preparedness is and what are the gaps. We can say that at this point, they are really moving forward in terms of the EOC, the Emergency Operating Center, which is activated, in terms of trainings that have been implemented, in terms of laboratory that are ready to test, as well as Kenya. So this intensification of the preparedness is really key, so that in case anything happens, they will be able to respond easily to these outbreaks. So now, in terms of vaccine, they have adapted the protocol that was used in Rwanda to implement the response here in Ethiopia. Now, in terms of other viral hemorrhagic fever, the Crimean Congo hemorrhagic disease has been occurring in Namibia, which one confirmed case, one death, and one zone that has been affected. This is the zone of Windhoek, which is on the capital city. So Namibia also at the same time have been facing Mpox with 2 cases that they've been able to well manage, and are now also facing an outbreak of cholera. So this is also highlighting a country that has really excelled on controlling those outbreaks at the source, with the key driver that we've been emphasizing: a strong leadership at the ministerial level, deployment of multi-teams, multi-response team, the community-based surveillance, but also the isolation and the proper management of patients, and of course, the data management. Next slide. The Rift Valley fever has also been present in Senegal and in Mauritania. As you see here, the Senegal that has been the most affected with 554 confirmed cases, 31 deaths, making a case fatality rate of 5.6%. Remembering that Rift Valley is a zoonotic disease, and you can see that the animal has been quite exposed with 434 cases, with up to 2,000 abortions that has been reported, which has an implication and an impact, economic impact for the people who are living from the animals. In terms of response, 51,000 animals has been vaccinated, covering a total of 324 villages. Next slide. Now, let's get back to Mpox, where we all start a while ago. So we are now 1 year and 4 months since the public health emergency of continental security was declared because of the unprecedented sustained human-to-human transmission, because of the rapid geographic spread to new African countries. You remember we were moving from DRC, where it is endemic, Central African Republic as well, and in the eastern part of DRC, that's where the mutation moving from the clade 1A to 1B has occurred. And following that mutation, it has been the spread of the disease that now moved from a zoonotic disease, animal to human to human transmission, also emphasized by the transmission through sexual ways. But also the rising case and fatality, the inadequate continental preparedness and response capacity, and the major risk of spread in other continents. That were the reason why it was declared as the FEX. Next slide. Now, where are we today? Today, we can see that significant decrease by 86% decrease from the time we were at the peak. In total, 243 suspected cases, 60,000 confirmed cases, 2,000 deaths among the suspected cases, with a case fatality rate of 0.9%, and among the confirmed cases, 292 deaths, going to a case fatality rate of 0.5%. Now, when you look at the comparison between this year, 2025, and 2024, you can see that we've more than double the number of suspected cases. Now, more importantly, the number of confirmed cases that moved from 90,000 to 40,000, a 200% increase. We've also seen that in terms of death among the confirmed cases, we really moved from 45 to 247. But as we do speak now, we still have some countries, though the decline has been happening in the majority of countries. We have countries like Liberia, Ghana, Kenya, Guinea, that are the one currently leading in terms of the increased number of cases and death as well. Next slide. So now when we look at the 4 high burden countries, those that were the most critical during this outbreak, we are talking about DRC, Sierra Leone, Uganda, and Liberia. They were contributing 96% of the confirmed case. So you imagine that when the decrease went in those 4 countries, definitely it has impacted the decrease within the continent. But what is also important here is to notice that different countries have been using different ways of responding to these outbreaks. While in Sierra Leone and Uganda, the vaccine has been a key player with a very targeted approach, in DRC, the intensification of the surveillance and the use of 2 types of vaccine has also been instrumental. In Burundi, no vaccine has been used, but rather the lab decentralization, the isolation of case, the proper case management and surveillance has been supporting the country to bring the curve down. So it's also a reminder that there is no one-fits-all solution. Each country is different, and even within countries, we have disparities, and we always need to adjust the response to the country and to the region. Next slide. In 2024, when the FEX was declared, Africa was expected to have not more than 20,000 doses of vaccine. If you recall at that time, we were already raising the alarm of inequity, which we also seen during Mpox and COVID. But now the game changer has been bringing all the partners together, the IMST, bringing the issue of Mpox at the highest political level, leading to an important mobilization of resources, but also of vaccine. As we do speak now, 5 million doses of vaccine has been delivered to 16 countries, 1.83 million of MVABN and 3 million of SC16, with 14 countries currently vaccinating. So now up to 2 million of people have been vaccinated with at least 1 dose, and the children between 1 to 17 years old account for 30% of the total population of persons vaccinated in the continent. But moving forward, with the will of eliminating Mpox, as we did in the past, we need to move toward having vaccination in the endemic zone, in DRC, in CAR, in some of those countries where Mpox has been there. And this demand, important demand of vaccine dose, will also be a catalyzer for the technology transfer and for the agenda of local manufacturing. A lot of engagement have taken place with the manufacturer, Bavarian Nordic, but the biggest challenge has been, what is the demand? So now that we are moving toward ensuring that we can reduce Mpox to the limit with that approach, moving in endemic zone, then we'll have the demand. Then we'll need to find the fund, domestic funding, global funding, so that we can have this local manufacturing of Mpox vaccine. Next slide. The Emergency Consultative Group, the ECG, we've mentioned that they sat last week, and then we are expecting the feedback. But you know, it's important to make a critical assessment, which is being done, but also it's important to ensure that the proper recommendations are in place. So we will receive those feedback by next week, and then we'll be able to communicate using the different channels. Next slide. Now, from Mpox moving to cholera, and as I mentioned, as we do speak today, cholera is definitely the major public health event in the continent. You can see the number of total cases, 300,017 in 2025, as compared to 100 in 2022. The number of cases has doubled. As compared to last year, we've added more than 50,000 cases of cholera. In terms of death, we've added almost 3,000 cases. You can see the case fatality ratio has increased from 1.9 to 2.3 in 2025. But you can also see the number of member states affected, moving from 20 last year to 25 this year. And we can see that the South Sudan, DRC, Angola, and Nigeria contribute to almost 90% of the cholera cases reported in 2025. Now, in terms of death, Sudan, DRC, South Sudan, and Angola together account for 85.4% of all cholera deaths that has been reported. Next slide. This is the reason why the head of state and government has requested two things. One, to integrate the cholera response within the IMST model with one team, one plan, one budget, one M&E, to accelerate, to catalyze the response to cholera, but also to set a continental task force, because now the idea is to elevate the issue of cholera at the highest political level, because the response to cholera is definitely not a medical one only. It needs infrastructure. It needs the Minister of Finance. It needs the Minister of Water and Sanitation. That's why this continental task force will now support the establishment of national task force, which the AU champion, the president of Zambia, will be supporting his peer head of state on implementing those task force in the countries. Next slide. Now, looking at the data themselves, we can see that as we said also last week, Eastern Africa was really the one leading, but as we do speak now, the major shift in regional case load, with DRC alone reporting 69% of cases in the last 3 weeks. That's why all the effort, most of the effort are also put in DRC, especially in those areas. Now, the challenge that we face with DRC, as you know, and as you will see later, is the conflict environment. Next slide. As you can see, as I was just saying, that we have DRC, which is one of the countries that's where we see the increase, with more than 3,000, almost 4,000 cases that has been observed in the last 3 weeks. We have also Mozambique, we have Burundi, and we have Namibia. So in terms of decline, sharp decline, we have South Sudan, Kenya, and Ethiopia with almost 55% of decrease. We have the moderate decline which is including Chad, that has actually declared the end of the outbreak last week. We have Angola, where we see the decline, but we come to that. And we have countries like Somalia. But in terms of high burden, despite the short-term decline, we still have South Sudan, DRC that remain the highest burden countries. Next slide. Now, as mentioned, Burundi is one of the countries where we've seen that peak, but we also appreciate all the effort that has been implemented. Our Director General was in Burundi last week, appreciating the multi-sectorial approach that is taken at the highest level on the side of the head of state, but also on the First Lady, bringing together the private sector, but also all the partners to ensure that we have non-medical partners, ensuring that they can improve the access to quality water, which remain one of the drivers of the cholera in Burundi. Next slide. In Angola, once again, this is a case study on showing us how the medical response, the vaccination alone might not be enough, especially the vaccination with one dose that we've used to control an outbreak. But what we are seeing is that in a country like Angola, with the evidence that we are generating, one, vaccination is not a silver bullet, but even when we go to vaccination, we need to ensure that the population have access to the 2 doses that will give a protection for 5 years instead of some few months. Now, if we have that protection for 5 years, it also gives time to the country to invest on infrastructure in WASH to ensure that if an outbreak comes, at least the access to clean water is there, and therefore we have a small number of cases. Next slide. Mention that as per now, the DR Congo is almost 69% of the case on the last three weeks, with a case fatality rate of 3%, with 1,939 deaths after the 67,000 cases. As mentioned, the hotspot, North Kivu, South Kivu, that is also where they were the hotspot for Mpox, for measles, and so on, but also that's the region, the provinces where the issue of armed conflict is still a big challenge. So we believe, as we keep on saying, there is no health without peace. We hope that the agreement that was signed will be implemented, operationalized, so that we can have access to the community, to the patient, and supporting them. Because once that is not there, we have that important movement of refugees now going to Burundi, which also bring another risk of spread of cholera and other disease in Burundi. Next slide. Now, in summary, this year has been a very busy year. We are glad to see that the number of events is less than last year, but you've seen that a disease like Mpox, we double the number of confirmed cases. Cholera, we triple the number of confirmed cases and deaths as compared to 2022. Now, in terms of Marburg disease and other viral emergency fever, we've seen that this year we've been seeing more and more of those ones. We've seen since last year in Tanzania, in Rwanda, Namibia, Senegal, Mauritania, and now Ethiopia, as we are talking about MVD. So this increased trend of viral emergency fever requires shifting from a reactive to a preventive mode. That's why it's critical to ensure that an emphasis is really pushed on the preparedness. And we welcome the pandemic fund that is going to support Africa CDC and 7 African countries, making a total of 59% of the fund that will be granted by the pandemic fund. As Mpox is concerned, the ECG will assess the lifting of Mpox, will provide the feedback early next week. And in the meantime, the transition roadmap is ready to support countries to integrate Mpox within their routine program. Cholera remained the major outbreak this year, with more than 7,000 deaths across 25 member states. So at this point, we really need to strengthen, to catalyze the research, because we need some innovative solution, including the presidential leadership that will be emphasized in 2026 to accelerate the sustainable measure toward cholera elimination by 2030. We talk about the medical response, we talk about a non-medical response that are the most critical to ensure the sustainability of a cholera response, moving toward its elimination. The IMST has shown this year that it's definitely the model where we bring all the partners together, especially in a time where the resources are limited. We definitely need to do more with less. So that collaboration that has emerged this year and should be strengthened in 2026 to not only respond, but more importantly, to prepare countries to address public health events in the continent, which most likely will include other diseases. We've talked about diphtheria, cholera is already part, but also other viral hemorrhagic fever. So I'm glad that I've been able to share with you some of the key highlights of this year, and now I will be very happy to take some of the questions. Thank you.
Thank you, Prof. Let's take the first two questions. We have one here from Saiku Jamer, is a New York Times reporter in Sierra Leone. And the question is, Sierra Leone has lifted the state of emergency on Mpox, according to news reports. I would like to know how they managed to overcome Mpox under what was earlier reported to be very difficult circumstances. And what does this achievement mean for the health emergency situation in Africa? That's the first question. Then we have a second one here. And the question is, how true is the news that CAD3 Marburg vaccine is deployed in Ethiopia for emergency use for high-risk groups, including frontline health workers, while it is still in the clinical trial phase 2? What is your suggestion on this? Back to you, Prof.
Thank you. Thank you so much for the question. The first one from our colleagues from Sierra Leone, how did Sierra Leone overcome Mpox? It's a very good question because you've been following us, and then you remember how critical the situation in Sierra Leone when we were seeing the peak really going up. We are seeing also the passive surveillance with most of the cases, between 80 to 90% of the cases were found at the hospital. And then we had that engagement with the IMST meeting the highest level of the country, the Minister of Health, and emphasizing the need to adjust the response and the need to strengthen the leadership. And what has followed has been an investment of the country in terms of financial support with 1.7 million that the country has invested in the response to Mpox. That's one. Secondly, they've really changed the strategy. You remember the key driver that we've mentioned, the leadership, the minister himself. You've seen him during the press briefing, highlighting how critical his investment, his involvement has been. Two, the community-based surveillance, integrated. They went from a passive to an active surveillance where we are having community healthcare workers doing the community, the communication and risk and engagement, but also the surveillance, ensuring that they will find all the cases in the community, and at the same time, implementing the targeted vaccination. So they implement that operation, Find Them Whole, that has really strengthened the surveillance. And also, they moved from a time where they were taking care of patients at home to a time where they were isolating and providing very good care of patients in hospital. So that has also cut the spread of the disease. And that the experience of Sierra Leone is currently being transferred in Liberia, where the IMST went together with the ancient manager of Sierra Leone to ensure that there is a South-Sound shared and lesson learned. So those are the key point that has been put in place in Sierra Leone. Now, in terms of vaccination, what we know at this point is that the government has been advanced in receiving I think 2,500 doses of vaccine, and the vaccine has started following a clinical trial protocol. We don't have all the detail, as you know, sometimes those protocols remain confidential, but they are following the guideline of the protocol and the research. Thank you.
Let's cross over to the floor. We have Esther Nakazi, is a science journalist in Uganda. Esther, you have the floor.
Thank you, Margaret, and thank you, Prof. I want to follow up on two questions. One is how Burundi, did you say Burundi did not deploy any vaccines, but it managed to bring down the curve, like Uganda and other countries? I would like some clarification on that and what exactly did they do? And then secondly, in terms of the DG's visit to Kenya to, propel local manufacturing of other therapeutics or vaccines, I would like to understand in terms of funding, are we as Africa CDC, what is the funding model we are looking at? Because we have an example of Rwanda that is coming up with the BioNTech industry, BioNTech manufacturing plant, and it was funded by the EU. I would like to understand if there is any level of sovereignty for Africa, if that kind of deal is made. Thank you, and over.
Thank you very much. Back to you, Prof.
Thank you. Thank you so much, Esther, for your question and follow-up. So good to mention and to come back to the example of Burundi. And before going into how they've managed, I think the lesson learned is, once again, there is no one-size-fits-all solution. So the success of Burundi started from the leadership at the highest level, getting involved in the response. I remember an interaction review in Burundi, led by the IMST, supporting, I think Dr. Gashi was the one leading the team. And during the 2-3 days of that review, that meeting, the Minister of Health herself was present during all the discussion. This is showing to you how critical this leadership has been, that one. Secondly, they invest on the laboratory decentralization. They move from one laboratory able to detect Mpox to 56, meaning that every single district of Burundi were able to detect Mpox. When you have that capacity to detect, then it reduces the time between someone is a suspect and once it's confirmed. And what they also did very well is the isolation of all the positive cases. Isolation and management. What does it mean? It means that they provide adequate care, which include the clinical care, the psychological care, but also the nutritional, because when people are in the hospital and they don't have food, they need to find food somewhere. They also provide that. So that holistic and comprehensive case management was critical to take care of the patient, ensuring that eventually they have one death for the entire outbreak, showing how good the care was, but also the ability to stop the spread of the disease. And on top of that, there were a community-based surveillance. We supported with the deployment of over 200 community health workers with different partners as well. So that understanding of the transmission dynamic, the surveillance, the isolation of case, the lab decentralization, and the highest leadership has really been instrumental for Burundi. But it cannot work in all countries because all the countries are different. Now, coming to the visit of our Director General in Kenya to push the agenda of local manufacturing, you recall now the improved vision coming from the time we listened to our head of state and government in September at UNGA, saying, how can we improve? We were having the new public health order. What are those new key components that we really want to add? Local manufacturing is one of them. So now you were asking about the sovereignty and how we'll manage in terms of funding. The first thing that Hawadidi is repeating all the time is Africa is a market, 1.4 billion people. That's a big market. So this market need to be structured. That's why we supported African pool procurement mechanism so that we can buy the medical countermeasure, the diagnostic, the therapeutic, and the vaccine as a pool. Now, if we have those mechanisms, if we also have the regulation agency, then we have the infrastructure to be in a position to regulate, to buy as a pool. Now, the other part is the actual tech transfer and production. So there is a country like Algeria, which currently is using up to 80% of the medical countermeasure they need. They produce 80% of the medical countermeasure they need. So it is possible. Egypt is also not far from that. So is there a market? Definitely yes, 1.4 billion. Is it possible? Yes. Now, the next step is the agreement with also all the other partners. UNICEF, for example, has agreed to support and to procure the medical countermeasure that will be produced locally. So once you have the Africa pool procurement, you have the different partners willing to buy what is produced in the continent, then we'll reach that Africa have sovereignty. Thank you.
Yes, let's take the next question. We have Abuja Rachel. She's works with the news agency of Nigeria. Abuja, you have the floor. Abuja, can you hear us? Okay, I think she may not be around. Let's pass the floor then to the next question. We have one here from Ongezwa Zibi, is a digital journalist with the China Global Television Network, or CGTN Africa. The questions, a couple of questions here. The first one is, what do you consider as the key health developments in 2025 for Africa CDC? I think you spoke about some of them earlier. And the second one is, what recent disease elimination achievements or outbreak responses have you been involved in? The third question is, what interventions did Africa CDC implement and what progress was made? And the last one is, what lessons were learned in 2025? Back to you, Prof.
Thank you. Those are quite a number of questions. So I will let later on my colleague, Dr. Charles Ibeneme, give an answer to the question of the intervention that was made by Africa CDC and IMST. Currently, we are a couple of countries where we have our team going to support. So he will be happy to give us a summary of what is happening currently. So in the key health development in 2025, as in Africa CDC, quite a number. I will start by what we present today, the response to the Mpox, where we are seeing the end of this outbreak using this new mechanism. I think the mechanism that is being put in place now that has integrated cholera as part of the disease that need to respond, I think that is an important development for the continent. But there are many others in the side of the primary health care where we are. This is the first time for the last few years that we have a dedicated primary healthcare directorate, which really push on the size of the increasing the community healthcare workers. The target that we have is 2 million. And the report that we have currently is that we've reached 1 million community healthcare workers. I think that is already an impressive achievement for this year. Some few also has also been implemented aligned that is our move in the digitalization on those community healthcare workers and the surveillance. Though it's still on the starting point, what we've done during the Mpox in terms of using the DHA, so this tracker that can help countries to detect, to actually collect the data in the real time. It was used for Mpox, then used for Ebola, now for cholera, And we believe that in 2026, it can move and scale at the continental level. I think that is an important one. But not to make a long list, I think the revise or improve or upgrade vision of Africa health, security, and sovereignty, it's an important development for the continent, because now, on top of what was already there, we've had the local manufacturing as a key component, we add the domestic financing as another one, but also all the other. And this is taking us to reshape the global architecture. So now for the question on the intervention, I will let Dr. Charles Ibeneme respond to that one.
Yeah, thank you so much, Prof. And good afternoon, colleagues from reaching you from Malawi. So just to quickly speak to those questions, in the past, between last month and now, we've been implementing some very critical interventions to countries, especially on the angle of Mpox and cholera. For Mpox, we are reaching out to 5 countries. I think that includes Ghana, where we provided support, to the country to expand the vaccination reach. And so far, we've been able to mop up more than 33,000 vaccines that was deployed to Ghana, and also able to re-strategize realign the strategy to be able to capture the very high-risk groups. The same is happening, of course, we did in Kenya, where the team were able to conduct some critical active case search in the country, in the hotspot regions, because this was very critical, even as we plan to deploy additional 20,000 doses in Kenya. And some of those critical findings from these investigations were, the burden of both Mpox and even measles within the communities. The team also did support Kenya in terms of the interaction review for cholera in Naivasha, and then as also conducting an RCCE, very critical RCCE activity that has to do with social listening. And then now currently I'm in Malawi, where we are supporting the MOH to conduct the very first ever Mpox IAR. And so far we've come up with very critical strategic activities that will be happening going forward. And so we believe that all of this would help to shape the response going forward and to also contribute to curbing the
Hello, Charles, we lost you.
Yes, maybe I can complete what Charles was talking about on the interaction review in Malawi and in many of those countries.
Thank you so much, and back to you, Prof.
Okay, thank you, Charles. Highlighting that many countries has getting that support from the IMST, which means now we've seen Charles from Africa CDC, but we also have some colleagues from WHO who are present together in Liberia, pushing the response, but also the research component, which is quite critical. So we are supporting our member state. I showed the example of Sierra Leone. This technical assistance sometimes is more critical than the other support that country can get. Over to you.
Okay, so let's take the next question. We have Abuja Rachel from the Nigerian News Agency. Abuja, you have the floor. Abuja,
good afternoon, Margaret. Can you hear me? Good afternoon,
yes,
Margaret. Yes, good afternoon, Professor Yab. So, compliments of the season. My question is quick. So, Prof, I would like to know how many frontline workers died in 2025. You made mention of some died from Ebola, and how are we being able to improve our infection prevention control when it comes to health workers on the continent? And again, as we wind down 2025, I would also like to know what, apart from cholera, what major challenges did we face as a continent, and what should we be looking at doing differently in 2026? And how close are we in achieving the public health order? Last question. I was expecting to hear the outcome from the Lukasa conference for One Health. What's the outcome? Thank you, and over.
Sorry, I did not well get the second question. And even that one, she mentioned Lusaka, but I didn't get it properly. If you can repeat,
Okay.
please.
Okay, Prof. I made mention of, I don't know if you had the one for health, frontline workers, how many deaths we have. Then the second question was on challenges of what major challenges did we record in 2025 and what should we be expecting in 2026? I don't know if you had the one for how we've been able to like improve our infection prevention control on the continent for health workers. Because in country like Nigeria and some other, you train them on IPC and we still see the same mistakes when it comes to Lassa fever and cholera. You know, they keep coming down with it and passing same infections to pregnant women and all. So for Lukasa, we had one health conference, not quite long. I would like to know the outcome if you were aware of it. Thank you and over.
Thank you. Back to you, Prof.
Thank you. I was not personally engaged in the One Health conference in Lusaka. But now coming back to your question, for Ebola in DRC, 4 health workers was reported had died. Those were the first one to take care of the index case, the lady that was reported as the index case. So we have the nurse, we have the lab technician, and so forth and so on. So as you really mentioned, it highlights the challenges on the training on IPC, especially in those remote environments where not only the training is needed, but the actual equipment, the gloves, and all those PPE that are critically needed. So those 2 gaps are important. So what has been done? So what has been done is first, as Ebola is concerned, that preventive vaccination. You remember I mentioned that in Bulape district, 44,000 people have been vaccinated with an emphasis on frontline workers to ensure that they are protected. Now, moving to Mpox, we've also seen that with the training that has been implemented in many countries, we've managed to reduce by 50% the infection rate of the healthcare workers, but we've not reported a death as specifically for them. So what is being done? The training, as you mentioned, but also the supportive supervision, not only bringing them in one room and training them, but really go in those hospitals to see their practice. And by training them in supervision, we also highlight the gap. Sometimes they know what to do, they know how to do that, but they don't have the means. So it's also where we talk about the stockpiling all those PPE that are critically needed and the sustainability of those ones. I think that's what is critical on the side of the frontline workers. Now, the challenge from 2025 moving to 2026, we will start with cholera. We have 25 member states affected. We've tripled the number of cases, the number of deaths as compared to 3 years ago. And we are still going in some countries to the rainy season, where we expect to have an increased number of cases. So that will definitely continue. Now, the other one, I mentioned the high-level meeting, advocacy meeting on diphtheria, that is moving across different countries. That is also something that we'll have to address as 2026 will be starting. Now, saying that, we have a new model of responding. We are pushing for more preparedness. We are going to rely more and more on the evidence that are generated by research. We also push those different diseases at the highest political level so that we don't see the response to those outbreaks only as a medical one, but rather at the multi-sectorial response, where we have all the ministers engaged to provide solutions to address those diseases. I think that is one of the critical innovation that we believe in 2026 will make a difference. And we have this roadmap for elimination of cholera. We want to accelerate. One IMST is one catalyzer, but we also rely on the Continental Task Force to ensure that we keep on leading that response. Over to you, Margaret.
Yeah, yes, and with that, Prof, thank you so much. We have come to the end of the briefing this week. I will hand over the floor back to you for your closing remarks.
Yes, at this point, allow me to invite Dr. Ngashi Ngongo, the incident manager of the IMSC, to provide our closing remark. Over to you, Dr. Ngashi.
Yes, thank you very much, Prof. Yap, and thanks, Director Margaret, for an excellent press conference. But let me just say, knowing that this is the very last conference of the year, I'm pleased to join you toward the end of this conference, just to thank our journalists for the journey that we have traveled together with them. This already more than 1 year. I think you remember we started in end of 2024. We've been with them throughout the year 2025. We have gone through everything, the successes, the stresses, and then finally these very good results that we've ended up by Prof. Yap just summarized. I would like to sincerely thank all of you on behalf of the Continental Incident Management Team and all the partners that are behind it. That's Africa CDC, WHO, and all the 28 partners that have supported this process. Let me just say that it is a very inspiring experience, so to say. We have taken very, very important lessons. I think one of them is in the broader context of pandemic prevention, preparedness, and response. That some of the great lessons we are hoping will prepare the African continent to be much better prepared for the next outbreaks and epidemics, and why not the next pandemic. If you look at the great result we had in with Marburg in Rwanda, or recently the Ebola response that Prof. Yap referred to in the DRC, I think that very important lessons about the leadership of the countries. I think we have to thank all our ministers of health and the leadership in the government. I think this is something that has really been demonstrated in all the countries where we see our African leaders stand up and take the lead. Things make a big difference. And then secondly is that we have learned how to take advantage of the technologies. Surveillance was one of the key bottlenecks, I think, when we started the IMST response. Getting just quality data was a really nightmare. But we have gone through that. We would like to thank also the University of Oslo that has worked with the IMST in the digitalization of our surveillance system. I think that's something that will carry us in the future. On the area of laboratory, again, thanks to Africa CC, thanks to ASLM, thanks to WHO for the great achievement in that area. You've seen also the expansion of laboratory capacity. It is true, we are not yet there, but out of 55 countries in Africa, if we have already 46 that don't have now the capacity to do genomic sequencing, it tells you we have come a very, very long way. I think those are some of the big tickets, so to say, that we'll be focusing on in the beginning of the year. And most importantly, it is now the expansion of this IMSC toward a much more integrated structure, a much more integrated response. We started with Mpox, but as you know, we were hit by Marburg, we were hit with cholera, we were hit with Ebola. As you can imagine, the global resources, the external aid was going down, but we're getting more and more outbreaks to respond to. I think that's why that integration is one element that has really helped. Today, IMSC is dealing with more than one outbreak, and next year we'll be really beefing up that capacity again to respond. I think to all of you, we would like to wish you a wonderful and blessed New Year 2026, hoping that really the grace of God may really overflow in all your families, in your personal life, and keep you strong again. And really goodbye to everyone.
Recording stopped.